in this presentation, I will talk about 3 to 4 parts proximal humerus fracture, reduction and suture fixation using arthroscopy. As said before, about 4 to 5% of all fractures are proximal humeral fractures, and 71% of these fractures occur in patients above 60, and 60% of the cases are with osteoporosis. Now, the treatment of 3 and 4 parts fracture, according to NEAR classification, is percutaneous fixation or open reduction and interfixation, or prosthetic replacement, and as was said before in previous presentations. But to our knowledge, there is no arthroscopic treatment present in the literature of 3 to 4 parts fracture. Now, in 2011, we developed an arthroscopic technique of reduction and transosseous suture fixation of 3 to 4 parts fracture of the proximal humeral fractures. Now, we do this technique for all 2 parts fractures, most of the 3 parts fractures, and some 4 parts. It is applicable for all cases, including cases with osteoporosis. The strategy of this technique is to have an arthroscopic reduction of the bone fragment and fixation with temporary K-wires. Then the fragments are sutured together. The temporary wires are removed, followed by a post-operative immobilization for 3 to 4 weeks, then starts exercise. The position, as mentioned before, is a sitting position with the standard 4 portals, maybe more. Now, the suturing system we use are 3 suturing systems. The giant needle suturing system, transosseous suturing system, the penetrating suture wire system. It is a wire with a suture fixed to its proximal end and a hand grip of its distal end, and the suture wire system, which is a wire with a hole at its distal end to pass the suture thread. Also, some special instruments we like to use is the concave node pusher. It helps to pass a sliding node and placing it in the place we need to or we want to, and the chop needle suture puller to pull the suture from the subacromial space through the skin from any place you want, not depend on the portal. Nowadays, for every case, we do a PSI model to evaluate the displacement of the greater tuberosity, the lesser tuberosity, the head, and its rotations. And that's helped us very much in the planning of the surgery. Now, the types of the arthroscopic reduction and suture fixation are the short vertical transosseous fixation with the giant needle, as described by Dr. Sharif. The horizontal transosseous suture fixation, also described by Dr. Sharif. These are mostly used in 2 parts fracture. And the mattress transtendinous fixation and the long vertical transosseous fixation, which is mostly used in 3 and 4 parts fracture. And if we use all of these together, they will make us the same symbol as the NATO, so we call it Natofix technique. The strategy of this reconstruction is based on reduction and fixation of the head to the shaft and fixing it with K-wires, then reduction and fixation of the greater tuberosity and lesser tuberosity on it, either if it is 3 parts or 4 parts, and suturing them with a mattress suture, and then suture all these together to the shaft with a longitudinal vertical suture. Now, in the 3 to 4 parts fracture, the head is mostly in varus angulation or valgus angulation. So the reduction is done for valgus angulation by abduction and rotation, and then fixing it with 2 K wires. This is the first step. In case of valgus angulation, we go with a spatula and push the head a little bit up to get it as much as possible in its anatomic position, and then fixing it to the shaft with the K wires. We go with the K wires distal or at the insertion or near the insertion of the deltoid. Now, in some cases with valgus fracture angulation, the greater tuberosity is displaced posteriorly. So the first thing we do, we reduce the head, fix it, and then reduce the greater tuberosity and fix it also with K wires. As we see here with a sharp hook, we are putting the greater tuberosity to its anatomical position and fixing it with K wires after fixing the head to the shaft. Now, the second step, we do the MATTRESS suture fixation of the tuberosities. This is by passing the giant needle through the tendon of the greater tuberosity, which is mainly the supraspinatus and some of the infraspinatus, and another suture through the subscapularis. Then the 2 lower ends of the suture will be pulled out through the instrumentation portal and tied together. After that, we pull the one upper end to pull the knot through the tendon outside the joint and cut it in order to have a suture without knot passing through both tendons. And then we make a sliding knot and push it together, push it inside the joint to compress the 2 tuberosities together on top of the previously fixed head with the shaft with K wires. After that, we put a guide on one of the K wires, fixing the shaft to the head. And then we remove the K wire and put in this tunnel the penetrating suture wire. So we can place the suture inside the joint. And then we cut it from the wire and put it with a chop puller immediately above the insertion of the supraspinatus outside through the instrumentation portal. And we pull the lower end and tie the 2 fragments, the head with the previously fixed tuberosities to the shaft. In some cases, if we want to use a special suture, we use the PS wire, the penetrating suture wire, as a loop and pass the desired suture through this loop and pull it through the bone and then tie it in the same manner as before. By doing this with an horizontal suture fixation for security, we get the Natofix technique repair. Now, this is a case of 4-part fracture with a head splitting and a varus impacted humerus. You see the head with a splitting fracture. And this is the fractured greater tuberosity. And there is a part of the head bone is fractured and displaced superiorly. Now we abduct the arm and pass the 2 K wires to fix the head to the shaft. And then we pass the 2 giant needles, one through the tendons of the greater tuberosity and the other one through the subscapularis. We have the sutures now passing through the tendons, and then we make our MATTRESS suture. Now, after having it passed, we pull the two upper ends and then tie the suture firmly using the concave node pusher, and compress the two fragments together. After that, we go to the wire, remove it, and put the penetrating suture wire with the suture from the shaft through to the head. And here is the penetrating suture wire with the suture going proximal to the head. We first use a ring forceps to pull the suture from away from the wire, so that we can pull it easily through the instrumentation portal above the insertion of the supraspinatus. And that is done then by using the chop needle puller, which is passed, and then we pull it through the tendon. After that, we make our sliding knot and fix the head with the two tuberosities to the shaft, and we review that for another suture or two or three sutures. And here is inside the joint after fixing the head and the fragment, and the suture is compressing the fracture inside. In some cases, we use a giant needle again to secure this fixation, but when we do that, we have to keep the fixation wires before doing that in order to avoid displacement. This is the case before surgery, showing the greater tuberosity fracture, and after surgery, we have a fairly good anatomical reconstruction. We reviewed 22 cases of 3 to 4 parts fracture from 33 cases done with arthroscopic treatment. The average age was 60 years. The average follow-up was 2.5 years. There were 18 cases with 3 parts and 7 cases 4 parts fracture. Rotator cuff tear was present in 3 cases, and 72% of the cases had osteoporosis. The result, half of the 3 parts fracture had excellent results. The other half were satisfactory according to Neer classification. While the 4 parts fracture, 29% were excellent, 42 were satisfactory, and 29 were unsatisfactory results. The complication were in 2 cases, 29% of the 4-part fractures were malunion, and 21% of the 3 parts fracture, while impingement symptoms were present in 2 cases. In conclusion, summary, the clinical and radiological results strongly encourage using the arthroscopic technique to treat proximal humeral fracture, especially in all patients with osteoporosis. Age and osteoporosis is not a contraindication. There is no complication of osteonecrosis or non-union because there is no disturbance of the blood supply. And it has a minimal morbidity. It's a one-day surgery, which is accepted by all patients. It is also a low-cost surgery. Thank you very much for your attention.